Hello.
Hi,
I just was checking to make sure my sound was working.
can you hear me okay?
I can hear you.
Okay, I'm Liz. Nice to meet you.
Hi, Liz. Nice to meet you. I'm Sarah Singer.
Your screen going in and out, or is it your projection of video is like going very 80s TV grainy on me? Interesting. Now you're clear. Your picture is clear, and the other picture is crazy. Okay.
Okay, well, at least it's not just a me problem.
Yeah.
Well, hello guys.
Hi,
Hey,
Can
Mike.
you hear me? You
yeah,
you saw me get set up. Or maybe not. I don't know.
a little bit. Yeah, we got a behind the scenes look.
I know,
Sure.
right? Right. Yeah, so sorry about that. How you guys
Good to
doing?
see you again.
Yeah,
Good.
it's good to see you, Liz. And so Liz, Sarah is one of the oncologists, hemonc docs at Adina. And Liz and I haven't seen each other since I think CORD, the Council
Yeah.
of Residency Directors in Emergency Medicine meeting in New York in like
2 weeks
2020
before the
maybe.
pandemic. Yeah, or like days before the
Yeah,
pandemic, like
right,
as it
right.
was hitting.
It was,
Yeah.
it was called the ER COVID meeting, the CORD COVID meeting.
I
Right.
can't even imagine.
Yeah, it was pretty crazy.
Where did this case come from? I'm just curious. I saw it from the publication, but where was the original case from, Dr. Weinstock?
Yeah, sure. So this case actually came from the hospital that I used to work at, Mount
Okay.
Carmel. And it was an actual case, actual documentation, all this stuff, because I'm guessing that you are asking that question for a reason.
Oh, no, I mean, it's just curious. This is so fun.
Right,
So anyway,
right.
just
But
curiosity.
nothing's made up. And I want to introduce you guys to Rick Pescator, a good friend of mine. I won't say an old friend of mine because
Well,
that
I'm
can be
getting old. It's good
misinterpreted,
to see you,
right?
Mike. Good to see you.
Good to see you, man. Good to see you.
How's
So,
everybody
Rick, you
doing?
might know Liz.
I know Liz. Liz, we've
Okay.
met
We
before.
cross
Good to see
paths.
you.
Yeah, it's a
Good to
small
see you
ER
again.
community. So, and Rick, this is Sarah, and
Nice to meet
she
you,
is
Sarah.
actually not only and most importantly hemoc doc at Adina, but she's also my neighbor. I'm her neighbor.
Outstanding.
I
Right.
weirdly walked past your house about 15 minutes ago trying to get the barks out of the dogs before this. So,
Well, I'm guessing you got some barks from Dexter. He
yes,
probably
yes.
ran to the fence and barked back. So, yeah, he is a big barker, that guy for sure.
Mike, how have you been? It's been too long.
I know, right? Right. I've been good, man. I've been good. Just doing all my stuff. Just finished the busy sort of spring, lecture circuit type of things. So that was really fun. We got to go to some really good places and conferences and grand rounds and all kinds of stuff. So really
Fantastic.
enjoyed it. Yeah, really
Okay,
nice.
good.
So, all right, I am going to do this. I'm going to make sure AK has not texted us. Nope. Um, and then I'm going to pull the PowerPoint up so that's ready to go when we're ready to go. And then, so for Liz and Sarah, these are all available on the website, my the EM Bouncebacks website.
Mhm.
And it takes a while because you have to like edit it and stuff. So it's usually up by like tomorrow early afternoon is typically when
That's
we get
That's
it.
really
So
impressive.
I know. See, I'm apologizing because it takes so long, and you guys are like, "That's impressive." So that's funny.
It's all about perspective.
Right,
I
for
still have
sure.
notes from this weekend that I haven't edited yet.
Right, 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 right. All right.
Apologizing in advance. I'm recovering from overnights, and that's not going so well as I get older in my
All
in my
good.
days. Yeah.
All
So
good. Yeah. Let me check with AK if she's having troubles getting in. I'll just put that on our sort of group text here.
Mike, there's a guy named Brandon Ham who you probably, I don't know if you recognize the name. You know Brandon Ham?
I think it was one of our med students, maybe.
I
Is
think
that
so.
right?
Yeah.
Okay. Is he with your
He,
program? Or
well,
where is
yeah.
he?
Well, he was with the program I was with. He's just graduating and he's coming back out your way. And
Oh,
I want to
okay.
make sure that the guys, he's just the best guy in the world. And
Wow.
he's going out back your way, and I want to make sure you guys connect.
Okay. All right. Nice. Nice. That sounds good. Yeah. I mean, so if he's finishing, then I probably haven't seen him for like 4 years, I'm guessing, or
Yeah,
3
yeah,
years or
but he
something.
still sings your praises, that's for sure. So,
Oh man, a modest guy like me, hearing that kind of thing.
Brandon's incredible. He speaks so high, and he's coming. He's going to be a mover and shaker in the great state of Ohio. So, I'll make sure he
That's
knows it.
good. That's good. And you guys probably know Mac Brown. Do you know him? He was a med ed fellow with Jess Mason.
Ah,
He and I just did a podcast this afternoon.
keep him
So
busy. Keep him busy.
interesting. All right, for sure, for sure. All right, let's give this one more minute here.
Rick and Liz,
And,
where do you work?
Liz is the boss at Penn State, right?
Not anymore. I
Oh.
stepped down from that role a few years ago. But yeah, I'm at Penn State Health in Hershey, PA.
Okay.
I took on an admin role in our department now, so I'm like the OBS medical director and assistant medical director for the adult ED, and I have a teaching position in our health system science office.
Wow.
That's what you want.
Yeah, I used
I
to be the PD.
I'm just a lowly. I've stepped away from clinical medicine as of Friday, and so I'm just a guy. I own a pink wine bus that does tours of bachelorette parties in South Jersey. It's great.
That is wonderful. Okay, I'm equally impressed with everyone here.
All right. I'm not sure, Liz, I don't know if you have any sort of inside track with AK or not, but we were texting a bunch this afternoon, so
I feel like I got short on the half and half. Did I?
I don't see that she's tried to join, because I could move her from participant to panelist, but I don't see her there. So,
Did she say that she could make it?
oh, for sure. Yeah. She even sent me
That's what
her
I
stuff
thought.
this afternoon or this morning. Yeah. Okay. All right. So I'm going to pause for just a second, so it'll help with the editing a little bit, and then we'll get this thing started. So thanks for the folks that joined. And of course, this will be recorded and available at the EM Bouncebacks website. And this case is an interesting one because it's one of those cases of, man, it's not exactly as it seems. And if you think you're sort of moving fast and can, treat them and street them as we do in the emergency department, and someone has a fever, so it's definitely from some sort of infectious process like pneumonia, we will see here, spoiler alert, that it's not always exactly like that. So I'm going to start off by sharing the screen here and just making sure everyone knows that there are no disclosures that are of significance. I think AK had some type of disclosure, and hopefully we'll see her in just a sec here. And you can see here this paragraph, financial relations of one of the more ineligible companies, primary business of working, the whole human health and well-being ownership interest. And I think folks will see that when the final diagnosis is revealed, this did not have anything to do with any of those issues. So that's good. And so if folks want to take a peek here, you do get 1 hour of free CME for joining, which is really nice. And we'll flash the QR code as we get towards the end here. So I'm going to introduce the panelists. I'm going to actually start with AK, who hopefully will be joining us soon. Liz is working on that, Associate Professor of Emergency Medicine, Penn State Health. Rick Pescator, who he and I have worked together for, oh my gosh, almost like 15 years, probably doing podcasts and doing lecturing. And he is emergency medicine physician. He's the chair of EM News. So the journal that it goes out to all emergency physicians. Sarah Singer and I work together at Adina Medical Center. She is a hem-onc attending physician, and she'll be able to shed some expertise here. And I hope by actually the fact that she's part of this doesn't ruin the surprise too much. And then Liz Worley has a lot of titles: associate professor, department of EM, as well as medical director for the ED OBS unit, assistant medical director for the adult emergency department. This is all at Penn State Health in Hershey, Pennsylvania. And I have actually been with you guys and have done grand rounds for you guys, and really enjoyed the opportunity to do that. So let me first tell you about the patient here. This is a patient, 75-year-old woman who presents with bronchitis. Can I ask real quick, can you guys see the slides here?
Yes.
Okay, all right, I'm just making sure about that. Okay, fantastic. All right. So I'm just checking my headphone here. So, and does my sound okay to you guys? It's okay, good. Okay, all right. Okay, so she's a 75-year-old woman. She is from Somalia, and we're going to see how some of that issue plays in just a little bit here. But she presents to the emergency department, and she has multiple complaints. She has head pain, neck pain, but there's no trauma, atraumatic neck pain, vomiting, and ear pain. And for the cynical amongst us, you could say, well, everything hurts and even her teeth itch, right? But look, this person is being genuine, telling you the symptoms that she has, and that's what we really need to know about. Her vital signs, interestingly, they take her temperature multiple times, but they only check her other vital signs one time. And when they do, she has some mild tachycardia, and her blood pressure is a little bit soft. So hard to say whether that is the normal blood pressure for her or not, because we only have this one. And she says, at least with the pain scale, that I don't do, right? But most of us don't really ask that question as far as physicians, but the pain is 10 out of 10. And she has, legit temperature, 103.3. She's had symptoms for several days. Her biggest concern for what was wrong with her, but she waves a language line, and I believe it's her daughter that actually helped with some interpreting, and that was from the picture here. So actually it's not, because that's a stethoscope. But at any rate, I'm just going to simply read the history, and then we'll look at the exam, just summarize everything. 75-year-old woman, history of hypertension. So now we see the blood pressure probably does normally run higher. And she has myalgias, chills, but no documented fever, at least according to this history, although she has an objective elevated temperature here. Mild sore throat, non-productive, moderate cough with waxing and waning headache, generalized gradual onset, resolved and then returned. And she has some associated nausea, occasional vomiting, and then the rest of the review systems are negative for chest pain, shortness of breath, back or abdominal pain, blood in urine, stool, bruising, or rash. Okay, so they document this is just after midnight, well appearing, well nourished, awake, alert, cooperative. Her throat is red. Her breath sounds are clear. They do actually, interestingly, a pretty good neuro exam. And sometimes we have these across the room neuro exams, and they give her some IV fluids. They do a chest x-ray, which shows a bibasilar density may represent atelectasis, but their thought was bronchitis, however, still treated the patient with ceftriaxone and azithromycin, and then got some labs. And her viral tests are negative, but she does have a thrombocytopenia with a platelet count of 81,000. She's diagnosed with bronchitis, prescribed azithromycin, and has to follow up with primary care. So why don't we just sort of start off here? And I think we are still sort of waiting for AK. Is that correct? She has not yet arrived. And that's totally cool, because I can take this question myself here. And this is obviously a big interest of mine, is how documentation plays out as far as patient safety. And what I would say is this: when you have a patient with multiple complaints, there's no better way around those complaints than evaluating each of those. And sometimes those complaints can all go together. And we always try to tell a cohesive story as far as those complaints. Like, is there head and neck pain because there's some type of meningitis, either bacterial or viral, or for some other cause, which could have the vomiting go along with that? Or does she have generalized myalgias and a sore throat from an acute viral process, and she just has a headache that goes along with it? Because most of the time when you have a flu or a viral syndrome, you probably have a headache with that. Okay, so that is the headache. I like the fact that they talk about the onset, that they said it started several days ago and it started gradually. I would have preferred a little bit more the timing. In other words, with the onset, did it start over seconds to minutes, or did it start over several hours? And sometimes the patient will say to me, yes, Dr. Weinstock, it started suddenly. And I'll say, well, what do you mean by sudden? They said they started at noon and it was really severe at 4 in the afternoon. And to all of us, of course, that's more of a gradual onset. As far as the neck pain, chills, vomiting, I like an additional question, and you've heard me talk about many times, this follow-up question in a patient with chills, just for example, and you think to yourself, chills, do they have a fever also? And sometimes I'll say, do you have a fever? The answer is yes. And I say a temperature over 100.4, and they'll say, oh no, nothing like that. My my fever is a headache, something, to that effect. So short version is this patient had presented with these different symptoms, and unfortunately, the history didn't really tease that out quite well enough. And as far as any sort of medical decision making, I sort of feel like the progress note doesn't really confirm that it's an infectious etiology causing that. So let's progress just a little bit here, Rick. And, she, and is documented on here, does not speak English. However, she waived a language line. How do we know she was even able to do that? What is your approach to patients who are not native English speakers?
I think it's a good point, Mike. And I think when we talk about what got lost in translation is not just what got lost in translation from the patient's primary language to English, but what got lost in translation from the patient's disease into the chart. You spoke so much about the kind of things that we need to see in the evaluation of a patient. And naturally, we need people to fill out the illness scripts completely. In a traveler who's shown up to the emergency department with a fever and a headache, obviously we need to complete the script to satisfy all the requirements when it comes to all the diseases of traveling, as well as, you said, meningitis. When it comes to specifically how we're incorporating the use of the language line into care, I don't think it's a secret to anybody that the presence of a language barrier with or without the use of language services is a risk factor for a bad outcome. I think the answer to how we utilize language services in clinical medicine is actively changing. There are, of course, governmental regulations that require us to use language services and make them available to patients. There's also, of course, we well know that patients sometimes prefer their own type of translation. Maybe that's a family member, maybe that's something else. And I think we all should recognize that as AI progresses, that is certainly going to play a huge role in this. And I would venture to say it's few clinicians who have yet to have the encounter of the patient sitting there with ChatGPT open on their phone, which I think is probably going to be a good thing.
Yeah, and it certainly will. I mean, in the end, there was a lot going on with this patient. This wasn't an ankle sprain. This wasn't a corneal abrasion. And that data gathering, about 90% of the time, we're able to actually make a diagnosis or drastically narrow that down just with the history alone. So we talked about the history. However, the exam, we have, and this is interesting, I just mentioned it earlier, 3 temperatures, but only actually 1 set of vital signs. Liz, where do you go from here with the patient where there is some diagnostic uncertainty, where the vital signs, could be concerning?
Well, this is actually a huge pet peeve of mine, because I can't tell if this is a templated or macro type of physical exam where they just forgot to change it and the patient was actually tachycardic on exam, or did it normalize by the time that maybe they got an antipyretic in triage and the heart rate was down in the 80s or 90s by the time you examine the patient. So I think the easiest thing to do is comment on it when you're evaluating the patient. I wear a wristwatch for a reason at work, and I repeat the patient's heart rate myself, or I'm looking at the clock in the room. And you can acknowledge it in the chart, tachycardic in triage, but normalized on my exam, or heart rate 86, whatever you calculated at. So doing the work and being cautious of using templated notes for that reason as well. The other part that kind of surprises me is that I would anticipate this person is probably an ESI 3 at least, based on age and risk factors, and she got labs and imaging. So I'm surprised that she didn't have protocol-driven repeat vital signs ordered prior to discharge. That part is just kind of flabbergasts me, and I think it provides an opportunity for improvement, and you have to always, that's like the last thing I check on every single patient before they leave my department, is recheck the vital signs. And if the heart rate was normalizing, maybe she got an antipyretic, the temp's coming down, the heart rate's coming down. As long as you can explain it away, I think that's the other thing too, is that right now, maybe the tachycardia is related to the fever, but they don't really explain it. I think if you can demonstrate improvement related to an intervention, or you have another explanation, then I think it's at least better supported in the documentation.
Yeah, and to tell you the truth, when you think of any type of abnormality, it's sort of nice to be able to explain it, to say why you think that is. And it makes a lot of sense when you think of tachycardia. That could be for pain, it could be from a fever. And it's nice to put in there why you think that's going on. So if the second heart rate was 80, just like you said, we'd be reassured. If you check it again and it's 140, we'd be super concerned. So Sarah, you have been so kind to be like there waiting for us patiently. But probably the most important question here is that there is another abnormality. I mean, there's mild tachycardia, right? There is, mildly low blood pressure, but the patient does have thrombocytopenia. Now, assuming that this is new, like we have a past platelet count, and they don't mention this in the record. And again, this is the actual documentation. Nothing has been changed. I mean, it's been shortened from all the, the anomalous stuff that's not relevant to our case here. But assuming that the previous platelet count was normal, what do we think about just this mild amount of thrombocytopenia? Is there anything additionally, and I know you're not an emergency physician, that we should do in the ED, or timing for follow-up, or even considerations for what could be causing the thrombocytopenia that could also be causing these patients other symptoms?
Yeah, I think you already mentioned a really critical component is, is this is acute or chronic? That's a huge factor. And there's a couple pieces of missing data that would be helpful here, like a differential and, the additional info from the CBC. But just looking at what we have here, I try to think about like what's the most common thing. And certainly suppression from an infection could be a potential answer here. Again, I sort of have the benefit of, further information,
Yes.
but, generally, I see a lot of suppression from viral infections, and like, it doesn't usually just pick on one cell line. Maybe like in that case, we see some pancytopenia. So it's possible, but the fact that the white count's totally normal makes that, maybe a little less likely. And then, maybe this woman is where you're kind of seeing her before she, gets sicker, and maybe this is a very serious infection and she's going to have an evolving DIC. So I think about, what's common. So I would probably say, suppression from an infection, and then what's really bad to miss. And that's how I just generally think about patients. And so what would be really bad to miss would be an evolving DIC or some kind of hemolytic process. So again, I'm not an emergency medicine physician, but I think, having a differential, a chemistry, looking at the bilirubin and LDH would give me so much reassurance. Is it an acute leukemia? Is it hemolysis? So even just those extra couple tests would be tremendously helpful. Diff, bilirubin, LDH.
Okay, so let me just summarize. Gotcha. Yeah, that's fantastic. And let me just summarize where we're at with here. So we have this 75-year-old woman. She is here with what they say or think is bronchitis. The physician, she has a problem list: fever. She has some tachycardia, maybe a soft blood pressure. She has 10 out of 10 pain with her head pain. And we don't really have a great explanation for why she has head pain. She also has this thrombocytopenia, which we're going to assume is new because it's not mentioned. And it's really questionable to me whether the physician even appreciated that there was an abnormality. Maybe this just sort of got lost, not only like Rick in your translation from, Somali to English, but also lost in the sense that there were so many labs and they weren't even aware that it was sort of low. So it would have been nice if there was some sort of mechanism for follow-up with this, as well as maybe even exploration if they'd had this in the past. Because in my experience, usually when you have a little bit of thrombocytopenia, they probably have had this in the past also. So she's diagnosed with bronchitis, asked to follow up with a primary care physician, and she is prescribed the azithromycin. And she gets aftercare instructions for bronchitis, which is not usually a bacterial process. So let's go through. Actually, before we do that, AK, you have joined us, and welcome. So glad to see you. And you and I actually wrote a paper, and then got interviewed for that also, on causes of fever that are not from infection. So do you want to give us a sort of rough, sort of bird's eye view of how we'd even start approaching this problem?
Yeah, for sure. Thank you, everyone, for your patience. I was laying an egg as my computer would not turn on at the most inopportune time. So yeah, the differential for fever, obviously the little acronym that I think we talked about is called I'm a hottie. And so it would be IM, which is infection or medication. There are certain medications that can induce fever. The A is autoimmune. I think the emergency medicine physician's biggest pain and enemy, and like, oh God, seriously, something autoimmune. But you have to think about that with fever. Hematologic is definitely an association with fever. Oncologic, different kinds of toxicities, they can cause fever. And then you have to consider now environmental, while that's not a fever, it's hyperthermia. But if someone's coming into the emergency department with a temperature higher than 100.4, I don't know that we're gonna really it's a fever to us. And so environmental is something to be considered. And then lastly are different endocrine processes. So when you see someone with a fever, 90% of the time it's going to be an infection, but the other 10%, you got to think I'm a hottie.
All right. And so, Sarah, can I just, I thought we were going to move on here, but you mentioned some of those oncologic things. The types of cancers that would be more common to have a fever, renal, maybe a lymphoma.
Yeah,
What other sort of cancers do you sort of like think oftentimes will present with a fever?
the only one that I truly have ever seen present with a fever is Hodgkin's or other high grade lymphomas.
Okay. All right. So good to know. All right. So let's move on. So as we know, the patient is sent home, and then she is back by squad 4 days later. And at this time, she is here with a family member, nausea, vomiting for 3 days. She says 10 days of myalgias, abdominal pain, cough, sore throat, headache, fever, a lot of different things, right? Seen in the ER to 4 days ago, similar symptoms, and fever up to 103, but unremarkable workup. Now, again, as you know, Sarah, you were saying, it would have been nice to have some additional part of that workup, which is easily able to be done in the ED, including, for example, bilirubin, maybe LDH, the differential for the CBC, white count, et cetera. She continues to feel well. Rapid strep was negative. They sort of summarized some of the stuff from the past visit. She still is elevated temperature, 100.3, and now she is, Liz, quite tachycardic. So not just the 106, 107, but 129. And her blood pressure is a little bit lower. She appears slightly short of breath. They said she's alert and oriented ×3. Again, from the documentation side of things, would be nice to say, and specifically, she easily readily knows the day, month, and year. However, maybe that's adequate in a patient to say alert and oriented ×3, although it sort of felt like the previous one, they weren't totally, reassured with that. So, Sarah, we're going to have you hold off on additional stuff just half a second, not to ruin the surprise here. But AK, where are you with a differential at this time? AK, I think you might be on mute if you want to unmute yourself.
I'm just rocking it tonight. So killing it over here in Ambler, PA. So the number one differential, just looking at that, right? Everything coming in with her is, you have to think sepsis, right? I mean, she looks ill. She's hypotensive. She's febrile. It's not that high technically, but she doesn't look well. It said here that, she's nausea, vomiting, whether she's confused or not. So the number one thing that I would go to right away out of the gate is sepsis. And then I would consider maybe some other things. But I think, we see sepsis so much in the emergency department that that's kind of our go-to.
And you know, sepsis, septic shock specifically, has a 30 or 40% mortality. And you compare that to a STEMI, which is maybe around 7% mortality. And you know, you can sort of bypass the STEMI patient, go to the septic patient, right? And of course, sepsis is being defined by end organ dysfunction, right? You know, from dysregulated host response, et cetera. So it's not just a fever, it's not just SIRS, it's actually septic shock is when you have that other constellation of end organ problems. And, you know, getting lactate, getting cultures, IV fluids, and then thinking about antibiotics toward that. But again, not to ruin the surprise, as it turns out, I will ruin the surprise a little bit. This does not turn out to be a infectious process. So, Rick, what would you do? You know, we talked about some of the basic stuff for sepsis, but what would you do additionally besides just some of those, you know, sort of, I guess, cookbook type of processes with fluids and antibiotics?
That's a good question, and I want to back up exactly what AK said, that 95%, 90% of the time when these people come into the emergency department, that are going to be septic, and just like Liz said, it's almost surprising that there wasn't some sort of gradated, policy-driven response to this patient. And I say that because doing all the things that we're supposed to do in sepsis for this patient will cover all the other bases at the same time, or at least get us going down the path that we're supposed to be going. And that's intentional. That's intentional because it recognizes that there are other things that we need to be keeping an eye on. That being said, I would submit to you that we often, have an opportunity to improve upon making sure we're doing all the things that we're supposed to be doing when the patient presents and is septic and is ill. When we look at the initial presentation, just as much as what we can look for what was lost in the translation, we can find what was sort of relayed in the translation between the lines as well, which was, this was an older lady who came into an ER with a fever, but looked mostly okay, but not all the way okay. So the ER doctor threw some antibiotics at them, right? And now you have a patient who's popping back in. All the things from the other day are still true. More stuff is true now. And just like AK says, this is a time to fire a bazooka at the patient, to go hunting for everything and everything that could be causing a problem.
So when I think of some of those harder to find causes infectious wise of fever, I think of things like spinal epidural abscess, like endocarditis, like pulmonary abscess or brain abscess, or some sort of necrotic infection like neck fash or Fournier's gangrene, all those sort of things. So Liz, specifically, you are at the bedside and we've done all the cookbook sepsis stuff. Is there additional stuff that you're ordering now, or do you want to wait until we get some of our initial tests back and then decide where we go from there?
Well, I think you have to look at it with the perspective of what were the abnormal results and the last ED visit as well. So in addition to all the sepsis stuff that we're talking about, I'd probably go broader than what she had before. She had flu studies that were negative, but did she have a full viral panel? I think that's one thing we kind of learned from COVID is, I get the big panel whenever someone's coming into the hospital. She had blood cultures that were sent on the initial visit. It's 4 days later. I want to know what those blood cultures, if they're growing anything. Is she bacteremic? She's got a really soft pressure. She's tachycardic. We all agree she sounds and looks sick. She probably has a one view, not great quality portable chest x-ray. So we may want to consider scanning her chest or scanning her belly, looking for something that we can't detect on a physical exam. And if we're considering chasing the headache that she's been having and we want to consider an LP and get CSF studies, I'm going to get a head CT first as well. So that kind of addresses some of the infectious stuff. But she was also hyponatremic on her first visit. So again, I want to see what her sodium is on this visit, and knowing that she was hyponatremic the last time, I want to add on serum osmolality, urine creatinine, urine lights, things like that. They may not all result in the ED during the hours that she's in the emergency department before she goes up to the floor of the ICU. But at least it'll help the admitting team. And the same thing with the thrombocytopenia that was noted on the last visit. I want to do some of those additional tests, which Sarah had already kind of hinted at with the LDH, a smear, looking at the fibrin and fibrinogen levels, different things that will definitely probably not result right away in the emergency department, but they're going to help the admitting team facilitate her care as well.
So I love where you're going with this, because what you're saying here is, look, we're not giving this 75-year-old a radiation-induced malignancy with the scanning, and chest x-rays do have limitations. Maybe the patient is super dry, she's tachycardic, maybe she has an infiltrate that's not going to show up. Maybe there is something on the head CT, or maybe we just like to have a negative head CT based on a person who's older before we go ahead and do that lumbar puncture, right? Because she does have a headache and a fever, which she had before. And to me, it didn't feel that they adequately ruled out some type of bacterial intracranial process, right? That thrombocytic, hyponatremia is pretty concerning. You know, you got 124. I mean, it certainly would be the realm of possibility that now it's 118. I always think of 120 as being sort of like the magic number with that, right? As well with the platelet count. So we're going to find out what happens here. And the actual emergency physician did a lot of stuff that you guys recommended. But we'll start just with the CBC. So she has a white count now of 35,000. Before it was 9.7, but her platelet count is now 8. Her sodium went from 124 to 121. And they do an ABG. I'm no fan. I'm really a VBG kind of guy. But at any rate, pH 7.52. Interestingly, PCO2 25. So she's blowing off a lot of CO2, obviously. And then she is hypoxemic on room air with a PaO2, assuming that is actually, they got the arterial specimen of 47. So we can talk about that part in just a second, because that doesn't really go along exactly with what the pulse ox is here. But more importantly, we recheck her vital signs. She's now significantly, even more significantly tachycardic and more hypotensive. So Sarah, well, actually, Sarah, we are holding you off here. Let me just start off, Sarah, with you, because even though our questions are a little bit different order here, to me, it feels like of all these things that I'm seeing, the leukocytosis and the thrombocytopenia would be the most concerning. How do you, Sarah, put this all together, if we would call you as an expert whisperer at this point in the evaluation?
So the first thing I would say is, where's the differential? Are those white cells blasts? Are they neutrophils? Is this acute leukemia? Again, you worry about what are the worst case scenario things that need treatment right away. Is this APL and DIC from APL? Is this someone who's septic and has hemophagocytosis? Is this HLH with, a bicytopenia and a fever? Is this DIC, or TTP, there's not that many things that will cause the platelet count to be this low. This level of thrombocytopenia really does narrow down the differential. Not many things cause the platelet count less than 10,000. You're looking at DIC potentially from an acute leukemia. You're looking at TTP, maybe ITP, right? But there's too many other things going on. This isn't an ITP. So this is what I'd be worried about.
Okay, so let's back up, and then we're going to come back to you just half a second here, Sarah. So, AK, let me ask you, with these different labs, what do you address first? Not as far as diagnostically, but any of these things that you're going to address therapeutically. In other words, to do anything specifically for these different abnormal values, or are you also just sort of waiting for more information? For example, a diff and a smear.
Well, I think, she's altered now. So we have someone who's altered with hyponatremia and someone who's altered with a platelet count of 8. So, does she have a bleed in her brain? Because it is less than 10,000, right? We know when your platelets are less than 10,000, if you sneeze the wrong way, you can start bleeding, right?
Right.
So, is that going on? Is her level of altered mental status due to this hyponatremia? I mean, she was hyponatremic before, but this is a little bit more significant. So I think you do have to start addressing the hyponatremia, right? So let's just say that her platelets are low and she does have a bleed. You can go ahead and, order the scan to see if there is a bleed. But if she's hyponatremic and she seizes in the scanner, I mean, that's just an all kind of mess of a nightmare that none of us really want to deal with. So I personally, like the leukocytosis, I mean, she has leukocytosis, right? Like, what am I going to do about that? That's really more of like a clue to lead me down a path of, is this an acute phase reaction? Is this a cancer? Is this an infection? Like, what's going on with that? But the platelets and the sodium, I think, are what are going to hurt her. If she's not actively bleeding, which we don't know what's going on in her brain, I think the first thing you do is treat the sodium.
Okay. So Liz, and I say this sort of facetiously and sort of as a joke, but she has a high white count. Obviously, she has a bad infection. Prove me wrong.
Well, she's, triggering all of the sepsis screens and all of that. But the one key component here is we're missing the actual source of infection.
Mm-hmm.
So like we don't have a definitive answer as to what's going on. Her urine culture is going to take 1 to 2 days to come back. Her blood cultures from the other day, we don't know that result, but her blood cultures today on the second visit are going to take 5 days. She hasn't even, we're not even considering, or maybe are considering an LP at this point. So we just don't have a definitive source, and we're not hanging our hat on the bronchitis diagnosis from before. She definitely has evidence of end organ damage. So assuming we have a source of infection, she's at least severe sepsis. And if she continues to be hypotensive after her fluid bolus, she's, kind of teetering right now on that septic shock range. Again, assuming we have a presumptive infection somewhere that is triggering all of this. But right now we don't. And we don't have other key results back that are going to help support that diagnosis, like her lactic acid, which I'm going to presume is probably elevated at this point. So she's definitely in shock, probably septic shock, but we're just missing that final piece of the puzzle.
So, Rick, before we get to Sarah to really do a deep dive into what actually turns out to be the diagnosis, and let me ask you about the hyponatremia, because we've talked about this a bunch. I mean, I talked about like the magic number of 120. I mean, she's 121, so she's close enough, right? What do you think is causing this hyponatremia? And I know we don't have all the urine labs as far as the SIADH stuff, but what do you think could be a differential of this?
Well, just like any time when a patient comes in with abnormal labs, the differential is going to remain broad. And hyponatremia, I think, is everybody who has clutched a green book in their hands has learned and gone down that algorithm more than a few times. And the answer is going to be just what we always suspect it to be, which is that it's multifactorial. There's some pre-renal component. There's some contribution of dehydration, just as there's probably a toxic effect as well, which, is going to bring us to, a very important question. And certainly we're going to tackle the diagnosis. But I would bring up something that I think is probably a paradox that I've encountered a little bit in my career, which is, as an emergency doctor, I've always thought that, I'm here for the crazy sick, insanely crazy, complicated patients. And that's true. But those are the patients that are probably the easiest to approach, because the algorithmic approach to those patients and the checking of the box of those patients is there for a reason. And it's those patients that we can adequately and accurately and rapidly address. So, just like the other doctors have said, this is a patient that would rapidly be fluid resuscitated, receive antibiotics, probably receive additional procedures, whether or not be a central line. And of course, there's a discussion to be had about lumbar puncture and platelet transfusion and such. So there's certainly a lot to talk about in this patient, but in the end, my suspicion is that it's always going to return to the value of checking all the boxes that we're supposed to check.
So Sarah, now is the time that I really pat myself on the back that I talked you into saying yes, although you said yes right away. So I think we're all good. But I'm so happy to have you here, because the big question is, could this be TTP? And then the next question would be, she has low platelets, should we give her more? So I'm going to put up the sort of pentat of TTP while you're talking. But I'd be really happy for other folks, to have a discussion here, because this is sort of a big deal. Can I ask you guys real quickly, can you see the PowerPoint slide of TTP right now? Or are we back to just seeing ourselves? Okay, good, because I switched to a different screen, so I want to make sure. All right, Sarah, you are our guest of honor, expert of honor.
Sure. Yeah, so I mean, the answer is yes, certainly this could be TTP. The thrombocytopenia is very concerning. And the one other little nugget of information was the patient's mean cell volume when she returned to the emergency department was 77. So she's slightly microcytic, which again, in and of itself, isn't very significant. I wouldn't get excited about that. But in this context, she's anemic. Most anemias, in critically ill patients are not microcytic. So that does raise my level of suspicion. But the critical component for TTP is there has to be some evidence of hemolysis. So we need to see the retic count, we need a bilirubin, we need an LDH, and we need a smear to look for schistocytes.
Well, before you keep talking, I'm going to give you some of that information here. I think it's on this slide, but it's on the last slide. At any rate, let me jump ahead to that point that she does have schistocytes, and this is what the hematology folks have to say when they get the blood film back. So I could just sort of summarize here, and then we'll go back to our previous slide where we keep talking, and then we'll find out what happens here. Predominance of bands, some promyelocytes and metamyelocytes, nucleated red cells, paucity of platelets. We are not surprised about that. However, significant schistocytosis, and they say microangiopathic hemolytic anemia and new neurologic changes. So now we have that additional information.
And then I'll go back to your question about, I believe the other part of that question was, should we give her a platelet transfusion?
Yes.
So I think, right now the answer is yes, for the reasons that the emergency medicine physicians already chimed in. She's altered, she could be septic, her platelet count's less than 8, she might need a lumbar puncture, she might need a apheresis catheter placed. So, regardless, and I know we'll discuss that, if platelets, do we give platelets to patients with TTP or not? That's a very interesting academic question, but the reality is if anything's going to happen to this patient, she's going to need a platelet transfusion. I'm not placing the apheresis catheter unless there's a platelet transfusion happening. So I would say right now she needs a platelet transfusion.
What is your magic number for platelets before you replace that catheter? 20,000?
20, 25, yeah.
Okay. Liz, Rick, AK, let me put the three of you at the bedside here, and you have your expert whisperer on the line here. Other sort of thoughts here or questions about where we go from here with things, or we're just calling HEMONC and letting it roll?
I'm not sure if this is the perfect moment to bring this up, but I do want to spend 1 second talking about the plasmic score. Is this something anyone in ER is familiar with, plasmic score?
Not this guy. Rick?
This is it's such a great tool. It's really well validated. It's been well studied. It was published by a group at Harvard, and it looked at patients who had confirmed TTP, and then they did statistical analysis to look at lab variables that were predictive of TTP. And there's a MD Calc, and you plug in, I don't remember the exact numbers. Are there platelets less than 30? Yes or no? Is there evidence of hemolysis based on a retic, a bilirubin, or an LDH? Does the patient have an active malignancy? Do they have a history of some type of organ transplant? Are they microcytic? Is their INR less than 1.5? And is their creatinine less than 2? These are all labs that the patient's going to have had done, that are quickly going to result. And basically, if they get a 5 or higher, this is 99% sensitive and 85% specific for a diagnosis of TTP. If they get, I'm sorry, I gave you the wrong number, 57% specific for a 5. If it's a 6, it's 89% specific for a TTP. And those are all labs that you're going to have back in an hour. And that's much faster than you're going to get the hematologist to come in from home and look at the peripheral smear, and certainly much faster then you're going to have your Adams TS13 come back. And so I think plasmic score is something that, we could look into to maybe, teaching people outside of hematology, our first line colleagues in the ER.
Wow, that is good. So Sarah, can I ask just a question with your own practice? You've been in practice for how long now?
4 years after
Okay.
fellowship.
Okay, after fellowship. How often do you see TTP?
Almost never. I've had like
Okay.
one.
Okay. Yeah.
Uh,
I mean, it's sort of a interesting thing that we learn about. I mean, it's interesting always to me in medical education. A lot of the stuff that we learn about is just like so rare.
yeah.
But yet we know the pentad of TTP.
So the
And yeah,
I'll chime in about the pentad is that it's historical, but
okay.
almost no one presents with the pentad.
It's because
And
they're dead.
right, by the time we have the pentad, the most common presenting symptom is gastroenterology, nausea, vomiting, stomach ache, diarrhea. 69% of these TTP patients will have some GI symptom. Um, and so I think the TTP, pentad, it's kind of interesting and it helps us remember some of these issues, but I think it's sort of, less helpful than looking at, the hemolysis labs and whatnot.
More for like a test. Okay, so let's move on here and give you a little bit results. What did the actual provider do? Then we'll get to decision point 3, which is decision point C. They have CT of the chest, cardiomegaly with some CHF, no infiltrate. Okay, so doesn't sound like we're making big changes based on that. They did a CT abdomen pelvis was negative. Interestingly, not a head CT, but just for the sake of argument, let's just say that was normal. They did give very broad spectrum antibiotics as well as some Decadron, and did also, Sarah, like you recommended, ordered platelet transfusion. Mental status continued to deteriorate, but at this point, and we had sort of jumped ahead for a second to what the smear had showed, but at this point, the etiology of her symptoms had not yet been determined. Decision point C. So AK, and we'll go through these things a little bit more quickly, probably 1 or 2 minutes for each of these. And again, folks, feel free to chime in at any point if there's a lot of expertise on this call here. So patient rapidly decompensating, is intubation into time, or should we think about BiPAP for some hypoxemia?
So, I mean, non-invasive positive pressure ventilation is definitely an option when you have those patients that come in where you're like, but they're usually alert. I mean, in the setting of an elevated CO2, that's probably one of the only settings where you can probably get away with using BiPAP. In her, if I recall her ABG that they did, she didn't have a particularly high PCO2. She's altered. She's getting worse. She's hypotensive. So this is not someone that I think is a good BiPAP candidate, because the last thing you need is aspiration on top of everything. This is one of those, like, you're standing at the bedside, you have your push dose pressors, you have fluids going, you have pressors going, you really are trying to resuscitate them as much as you can to get them to that point where you need to get them hemodynamically to intubate them, because they will otherwise crash. But definitely, if I'm going to teeter around with anything, it's not going to be BiPAP. It's going to be with continued resuscitative efforts to make them a better intubation candidate.
Okay, got it. And in a lot of ways, when you think about BiPAP, which I mean, literally, I love, I'm sure we all love, like life itself, right? But it's really the best for a process that is fairly quickly reversible. Like, I mean, heart failure is the classic thing. Like when I started practice in 95, like if you had bad heart failure, flash pulmonary edema, escape, however you want to call it, right? Those patients all got intubated, and BiPAP, using that as a bridge until your meds kicked in, nitrates, and then, diuretics probably, those are the really, really good times for BiPAP, but there are certainly some risks for it. So Liz, if we did decide to intubate this patient, what would be some things that you would do to increase our chances for successful intubation, medication-wise, as well as other techniques?
Yeah, if she's not already on pressors to support her blood pressure, because I don't know where she is with her fluid bolus, but she should have some vasopressor support going on. If she's not on them as a continuous infusion, I'd have push dose pressors ready to go and be administering that in small aliquots immediately prior to intubation and post intubation, because the positive pressure ventilation is going to tank her pressure even more. So I'd keep doing that and then having a drip ready to go immediately after the intubation, because I'm assuming her blood pressure is only going to get worse. And then you also have to be a little more selective on what drugs you use. So in this situation, ketamine might be a really good option because it's not going to decrease your systemic resistance. So it's probably the best agent to, not affect your blood pressure.
Okay, awesome. And would you, if you use the ketamine with a paralytic like rocuronium, or are you just using ketamine as a sole agent?
I'm not 100% sure what I'd do, and I'd probably make a game time decision. I'd probably try the ketamine, take a peek just with the
Okay.
ketamine alone,
Okay.
because she's going to be incredibly relaxed. But if it's looking difficult, then you can always add the agent, add the rock on if you need, but you got to be prepared that she's going to be paralyzed for the, next 30 plus minutes.
Right. Let me ask you one other question here. Also a fish or cut bait type of question. We have this CT, cardiomegaly, some CHF. Now, of course, we'd look probably at the film ourselves too, right? But are you giving this patient, because we had talked before about, sepsis, septic shock, right? The whole 30 cc's per kilo of IV fluids, or are you giving a smaller amount with this, assuming the CT scan finding came back before the IV fluids got started?
I would defer the large fluid bolus, and I'd opt instead for vasopressor support.
Okay, got it. And then one other consideration certainly would be bedside ultrasound focus to look at the
Yeah.
heart and all that type of stuff, right? So that certainly is something that can be super helpful right at the bedside too. So Sarah, I'm going to defer this question for you just for half a second, because we're going to find out. We're going to ask this in just a second. But Rick, thoughts on where we are at this point, assuming that we don't have that smear back yet, and then we'll just have Sarah sort of say, if this is TTP, how are we going to make that definitive diagnosis? And then we have the MD calc thing that you talked about, Sarah. But as far as that additional stuff, and you can sort of go into a little bit more of what they found and interpret that for us. So Rick, summarize where we're at, and do you agree with what everyone has said, or would you handle things a little bit differently? We all, I mean, I'm guessing 4 different people, I should say 4 different ER docs plus hemonc, obviously, but probably we'd all do things a little bit differently because just the nature of the beast. But where do you think we're at this point?
Well, I don't think we're in the greatest spot. I think we got an old lady who just bounced back to our ER, and all her labs and all her vitals are messed up. And because of that, I think we have a responsibility to do all the stuff we know how to do. And I would agree with Liz when she says she'd tube the patient. I would as well. I think that ketamine's a great choice. I use rocuronium every time. And this patient's gone to the ICU 100%. I think consulting our hemonc colleagues early is a fantastic way to do it. And, Dr. Singer mentioned the MCV. And, I think we as emergency physicians dutifully inspect the MCV on our patients as they departments, but maybe not. But maybe that's a good reminder that we do need to pay a better attention to that differential. I see in the comments here, we have some emergency medicine luminaries joining us. And I think that all of them would point toward what I think they know I'm getting to, which is an incredible article by someone I think we all know well, Josh Farkas, on PulmCrit, that talks about the neutrophil to lymphocyte ratio and the skill for it. And the reason I bring that up is simply this, is that as AK has said, as Liz has said, as Sarah has said, as you said, so we got the sick patient here. We're still not completely sure what's going on, but we're pretty sure she's sick if we haven't figured that out yet. And using as much information as we can and that's available to us is important. That neutrophil lymphocyte ratio may be one of them, but in the end, where we're at is a super sick lady who needs a lot of intervention, should get all that intervention.
Okay. All right. So let's move on to this point here, and we'll certainly get that QR code up there for folks to get their CME. So Sarah, I'm just going to read this very briefly, and then I want you to interpret it for small brain to me and anybody else who is not a hematologist. She has declining mental status, declining respiratory failure. She did get intubated. She is on vasopressors. And then the next one in hematology, blood film granulocytosis, predominance of bands, promyelocytes, metamyelocytes, nucleated red cells, paucity platelets. Primary abnormality is schistocytosis, microangiopathic hemolytic new neurologic changes. And they're planning on doing the pheresis. And as we know, she did get those platelets here. So why don't you, if you could, we'll give like 2 minutes, if you could sort of like interpret that for us. We'll all give our take-home points and then put the CME QR code up on the screen. Up, Sarah.
So it looks like on the blood smear, they saw kind of a stress reaction. This is a sick woman with a stressed bone marrow, and there's some reactive findings. There's, neutrophils and some immature white blood cells, but importantly, no blasts, no acute leukemic cells, which is helpful. And then the most significant finding is schistocytes, and these are really just fragmented red blood cells. And that's why this is a microcytic anemia, because those fragmented cells are smaller, than your typical red cell. So that shifts your mean cell volume. And that happens, TTP, you get these giant clumps of platelet and von Willebrand factor, and it causes thrombi in the vasculature. And so the red cells get fragmented as they pass through those small thrombosed blood vessels. And so that's what they found in the smear. And the way that we definitively diagnose TTP is with an Adams TS13 level. And that's a protease that cleaves von Willebrand factor. So, normally there's an adequate level of that protease. And so our body can break down and clear these giant, platelet von Willebrand complexes. But in patients who have TTP, they don't have adequate Adams TS13. And that, like in this lady, is typically immune mediated. There are other cases of hereditary TTP. And so you need this Adams TS13 level. A level less than 10 is diagnostic. A level that's in between 10 and 20 is sort of unclear, requires, expert interpretation. And then above 20, this is not your diagnosis. But clinically, Adams TS13 for us, like here at Adena, that's a send out test. It might come back in 7 to 10 days. At bigger academic centers that have, a heme lab on site, that could come back in a couple hours. So if you're someplace that has the ability to run that in real time, it's okay to wait on that. But for most of us, we would have to initiate treatment based on the plasmic score and not wait on an Adams TS13. So the treatment is with plasmapheresis, and the idea is, you basically pherese out those giant platelet von Willebrand factor complexes, and you also give steroids. It's about a mg per kg of, prednisone or whatever IV equivalent to that you want to give per day, and you give steroids and plasma exchange daily until their hemolysis slows down. So you check their hemolysis labs at least daily. And then within the past couple years, there's a new drug called caplacizumab that's been approved, and that's now recommended immediately if you have TTP, or if you have a high suspicion of TTP and you're waiting on your Adams TS13, you should give caplacizumab right away. And that was published a couple years ago. That was a New England Journal article. Dr. Catalan, one of my mentors at OSU, was an author on that study, the Hercules study that led to the approval of caplacizumab. And then there's also a role for rituximab. It's a little bit confusing now how you sequence caplacizumab and rituximab. But for the most part, caplacizumab is given more acutely, and then you can give the rituximab later because it doesn't work quite as acutely. And you continue the caplacizumab, until there's a response, sometimes for up to 30 days. It's extremely expensive. It's not available at every institution, but it's very effective, and it reduces the risk of relapse, um, and so that's kind of an exciting addition to the TTP.
It's awesome. And it's awesome that you worked under, or with, I should say, a person who actually came up with that. So we'll come back to all of us, just have a second here. Here is the code for CME. You can do that. I'm going to come back to this in half a second here, but I thought we'll start with AK. If you could give us like just a 30-second, what would you like folks to take away from being here tonight or listening to this in the future, this podcast with all of our expertise on this call here? So we'll do AK, Rick, then Sarah, then Liz.
Well, I think the biggest thing is you're going to practice to whatever resources you have. And so in terms of treatment, and I know this very well now that I'm really no longer in academics and I'm working at like teeny tiny little places around the city now. But the one thing that you can control is your differential. And I think not anchoring and keeping a broad differential, like taking a step back, especially with these people who come back again, and kind of looking at it from a broader stroke than the person before you. That I think is the biggest take home from this.
Gotcha. Okay, Rick, you're up. 30 seconds.
I think that those are tremendous takeaways, right? If you don't think about it, you don't think about it. All that being said, when we look at this case, we can look at both the first presentation as well as the second, the things we could have done better the first time, things we could do better the second time. And in the end, this is a patient who came to the emergency department with objective evidence of illness and was sent home despite that objective evidence of illness. And whether we need to believe what the patient is saying or we need to believe the labs which are placed in front of our face, one of them we need to believe.
Gotcha. Sarah, 30 seconds of take-home points.
I think, just paying attention to those CBC results and getting a sense of what are the common things and what's kind of the worst case scenario here with thrombocytopenia. And then, with the white count, if it's abnormal, you just always need a differential, can be added on. You don't even need to stick the patient again. And that's probably the most important. And the plasmic score, I think, is very helpful.
Years ago, we had and put on MRAP also at a conference at Ohio State, and Colin Cade, one of the ER physicians at OSU, said about not this patient, but a similarly confusing, it was like, this is not the one to increase your throughput numbers on. This is one where you sit down, you get a really great history, great exam, you go through all the different tests, the abnormalities, and you try to put all that together into a cohesive story. Liz, 30 seconds of take-home points.
All right. First, reassess abnormal vital signs. Don't send them home with abnormal vital signs unless you can explain it. Address abnormal lab results. Determine if those are acute or chronic. If you don't know, you also have to explain what your plan is to address those abnormalities. And then I'm a real stickler on documentation. I hate templated notes. I probably over document to a fault. So I'm particular about my medical decision making and what goes into each note, and when I amend resident notes and APP notes.
Got it. All right. Folks, thank you so much for spending an hour of your time with us. I know I have learned a lot. I hope we all have. And this was a tough case. It's not really even just the diagnosis of TTP, but an approach when there are multiple complaints and how we put that together in a story, how we explain that in our documentation. And that's going to really be the best thing that helps us to improve patient safety in this game. So again, thank you so much again to our marvelous panelists. Thanks to folks who have spent the hour with us. And we will see you in October for our next Bouncebacks when we go to chapter 29 of the Bounceback Critical Care book. And we'll have October, November. Then we will be done and have to figure out whether we're starting from the beginning or where we go next. All right. Thanks again, everybody. Have a good night.
Thank you.